It is just a huge honor for me today to be podcast interviewing Joseph Adam Rodriguez, CRNA, and CRNA stands for Certified Registered Nurse Anesthetist. He is a Pennsylvania native. Joseph has been practicing anesthesia since 2012 after finishing his anesthesia training at Thomas Jefferson University in Philadelphia. He began his practice in Phoenix, Arizona, gaining extensive experience in anesthesia care for the elderly, as well as upper extremity and lower extremity regional anesthesia. Joseph currently practices in Prescott, Arizona, and oversees anesthesia services for numerous facilities throughout northern Arizona. He is the medical director at Tri-City Surgery Center. In his various roles, Joseph has led facility teams to implement standardized processes for preoperative screening and evaluation for outpatient surgery, and helped to establish new surgical service lines, including total joint arthroplasty. Joseph has been involved in his local community since his youth, becoming an Eagle Scout, serving in his church, the former president of the Arizona Association of Nurse Anesthetists, and currently participates in government affairs at the state and national level. In his personal time, he enjoys strength training. That's how we met. And just kidding. Science fiction novels, and spending time with friends and his wife of 10 years. Managing partner, Arizona Anesthesia Solutions. Former president and former government affairs chairman, Arizona Association of Nurse Anesthetists. Certified registered nurse anesthesiologist with leadership and management experience, an interest in healthcare policy and economics, and a clinical interest in ultrasound guided regional anesthesia. Arizona Anesthesia Solutions, which is AZAS, is a team of full-service anesthesia providers. They can provide all of your outpatient and office-based anesthesia needs, from IV sedation to general anesthesia. Their providers are all nationally board certified as certified registered nurse anesthetists and trained in advanced cardiac life support. Each provider has their own liability insurance and is trained to handle any and all anesthetic emergencies. Their providers are very rapid-acting medications that can cause the patient to become sedated in a matter of seconds and become fully awake within minutes. This type of anesthesia will increase patient safety, office efficiency, and patient satisfaction, as they will able to return home and not have the long-acting sedative and delirium effects that come from other more commonly used longer-acting anesthetics. They are committed to keeping their prices low to increase the community's access to needed care. They currently operate in the Phoenix and Tucson metro areas, along with Prescott, Flagstaff, Yuma, Sierra Vista, and San Carlos. Arizona Anesthesia Solutions is committed to bringing high-quality, safe anesthesia to your office when you need it. When it's 1 day a month or 5 days a week, they're here to provide all your patients' needs. And the reason I brought you on the show, not just because you're an adorable, handsome guy who lives up the street, is because in Prescott, I'm down here in Phoenix. But the bottom line is, I hate to be that guy, but I became a dentist in '87. And I wrote 4 articles for the Journal of the American Dental Association. They published them all. But when I got the magazine, they had edited it down to where it was all sweet and fluffy, and they took out every Howardism that I wrote. And when I call them, I'm like, what did you do? And they're like, well, Howard, we can't say that. And I'm like, well, I say that. They go, I know you do, but you're kind of weird that way. And people don't realize that, my dentist homies don't realize that, when I look in the mirror, I'm a dentist in '87. But when I started my own magazine, because the ADA, I wasn't going to have anybody edit my shit anymore. You know what I mean? So after 4 edited articles, I said, okay, I'm going to do this myself. Well, that makes me a journalist. I have a media company, and media company, everybody loves media if they say you're gorgeous and handsome and all that, and they hate media if they call you on your own shit. And here's where I call them on their shit. So when I became a journalist, malpractice companies, and I don't want to say their names because it might get back to NCMIC in Iowa or different dental malpractice companies, they'd send me their monthly claims because in their mind, they're like, I want your dentist to be aware of these claims, you know what I mean? That, stuff can go wrong, and, they wanted the journalists to know what was going on. And my God, if it was ever 6 figures, if it was ever $1 million, somebody had an IV in their arm and they were dead.
Yep.
And then I see these like Joan Rivers. The most famous comedian in the world. She just goes in for some know-nothing little, remove a little lump on her larynx, and she's dead. And then it was Britain who sat there and said, granted, oral surgeons hardly kill anybody. I mean, it's like 1 out of a million, but their rate was still twice the death rate if an anesthesiologist did it. Wow. And then they were telling me, because I lectured for the Royal College of whatever that is in London, and they were telling me that my gosh, that nobody in America in a hospital is allowed to do the bypass and the anesthesia. Right. It's separated in every hospital. Well, where is it ever not separated? At your local oral surgeon, your local periodontist, your local these guys. Yep. And they say it's rare, but Joan Rivers, it ain't rare. She's dead. And so I got all these young kids. A quarter of our viewers are still stuck in dental kindergarten school. And a lot of them come out and say, well, I want to learn IV sedation. I'm going to go. And there's some big organizations like docs and things like that where they can go learn that. And I say, dude, you're not an anesthesiologist. And if someone dies, they're going to put you on the witness stand. They're going to bring some guy like Joseph to grill you for 5 days and make you look like you have a head injury. And you don't, I mean, what is your worst case scenario? Like when you jump out of a perfectly good airplane because you want to parachute, that's a bad trade. What did you get to gain? Nothing. What did you get to lose? Your life. And then I had 4 kids. I didn't actually have them. I made them. That was the hard part. But when my spouse, when she delivered them in the middle of the night, the first 3, she had naturally, because obviously this is America. Only a man named Dr. Lamaze, who never had a kid, could convince you to just breathe heavily. I always said, I want to pull his 4 wisdoms. I want to get Dr. Lamaze in my office, have him hold his wife's hand and just say, it's pressure, just blow, just breathe. I'm going to deliver 4 baby wisdom teeth. And the 4th one, she just lost it. It was in the middle of the night, and she lost it. And I said to the doc who delivered all the first 3, I said, yeah, get an IV. I want an epidural. Just do it. She's losing it. And he goes, I don't think she needs one. I said, doc, do it right now. He set a little pager on that. Back in the day, it was a little Motorola thing, put in the numbers. And in like 5 minutes, a guy that looks just like you walked in there, and I said, well, where the hell were you? And he goes, I just sitting at the IHOP. I just sit there and read a book. And he gave her the epidural, and it was so much easier. And some of the dentists I know that do the biggest cases, they don't schedule Friday, and then Friday they go in and do the big cases. And they don't do the sedation. They have someone like you come in. In fact, some of these cases that I did over the years is like, okay, so anesthesiologist is going to put him to sleep. Well, I'm not going to go in there and do 4 molar root canals. I'd rather get an endodontist to come in and do those 4. And you're just kind of like the concert symphony. What's the head of the concert symphony guy? The conductor. Yeah. I'm the conductor back in my office, posting on Dental Town why an anesthesiologist got him to sleep, while an endodontist is doing 4 molar endos, and then a periodontist places some implants, and then I make the most money on the whole deal. But I want to start with the most controversial section that'll make you the most enemies and make even more people can't stand me.
Oh, I like you a lot.
And that is, do you think these kids at AT Still and Midwestern should go learn anesthesia in some hotel course and start sticking IVs in people? Or is that like jumping out of a perfectly good airplane with a parachute?
Sure. Yeah. So I think I'm going to give you my opinion, but I'll give you the opinion of a learned, a dental surgeon, right? Who actually we were just talking about this, and he said, the thing which concerns me the most is not physicians or CRNA anesthesiologists getting more involved in dentistry. The thing which concerns me the most is exactly what you just described, right? Which is folks who they have a reasonable understanding of the physiology and the pharmacology, right? And they do something occasionally, and most times it goes okay. But in anesthesia, the way that comorbidities work and the way that negative outcomes work, it's a volume game. And the only way you're going to truly be able to have not just the knowledge, but also the experience to handle those emergencies is volume, right? When you're doing something most days, every day, the average CRNA or average physician in anesthesia probably does, I don't know, anywhere from 500 to 1,000 cases a year, right? And if you're doing basic IV sedation, you're only doing it a handful of times a year or once a month. Not only is that not a lot of volume, it's not a lot of exposure to the things which can happen, which are the emergencies. There are laryngospasms, the status asthmaticus, someone has some sort of emergency in the office, right? And that's why that's arguably, again, I think if I was listening to myself, I'd criticize myself and say, well, that's in your financial interest, of course, to say that, right? And, that's, of course, I suppose the less dentists that are doing their own anesthesia, the more that companies like ours benefit. I'm fully out there with that. At the same time, what I am saying is verifiably true, right? You ask a PhD in anesthesia how negative outcomes work, and it is certainly very much a volume game, right? You need the exposure, and the only way to handle those negative outcomes is to have the exposure.
And when you go on trial in public television, social medias these days, we've had, since I've been here, I can tell you, hell, we had 2 different deaths in Yuma.
I know about them. I read the reports from the board of dentistry.
Well, let's go there, because number one, when it gets on TV, they're never going to say, and we'd like to talk to the mother who had a 3-year-old child that had 12 cavities and needed to be put down to anesthesia to have 8 root canals. No one's going to say, why the hell does your child need 8 root canals at 3? It's always going to be, my daughter is perfect angel and she's dead. And I have 4 boys. And, I could see both sides, but now I have 6 grandkids, and the girls, I mean, I don't care if they needed a full denture. If you killed my little,
right.
Taylor Marie, I mean,
it's an absolute tragedy, no matter what the age, but especially when you're young. Yeah,
it's the worst tragedy in the world. So let's start there. So in Yuma, was it an anesthesiologist and a pediatric dentist? I mean, were they
right?
Was the training all there, or was it?
Great question. So I think the one that really got the attention was, I think they're both children involved. The one I read about the most was one where there was a dentist anesthesiologist. And that's probably a good segue, because there are different types of anesthesiologists, right? You have CRNAs, which you said sort of a registered nurse anesthetist, or increasingly known as nurse anesthesiologists, physician anesthesiologists, and dentist anesthesiologists. And that's something that a lot of people don't know, is that a lot of professions are involved. Anesthesiology just became a specialty in dentistry recognized by the ADA, right? Just last year or the year before. What happened there, and I hesitate to criticize the practice of others, I wasn't there, but just reading the notes, what appeared to happen is that a practitioner was put in a very difficult position, high production, and he relied on the expertise, there was not a registered nurse. It was a dental assistant who maybe she went to one of those weekend courses. I don't know. But they did not recognize that the patient was becoming hypoxic in the recovery room. The dentist anesthesiologist dropped the patient off, said, hey, the patient's waking up. They're going to be recovering. The patient was hypoxic. They did not, and this is the tragedy, they did not have oxygen in the building. They ran out of oxygen. They didn't even know. And that assistant who was watching kept silencing the monitor. Right? The standard monitor, you go below 92 or 90% and it rings. She kept silencing. The kid became hypoxic and a very tragic event occurred. And again, this is my reading, I don't want to step on anyone else's toes or anything like that. That's my reading the Board of Dentistry's notes and all the different testimonies that went into the meetings over a number of months, because that made, national news. And that's, anesthesia and dentistry has certainly been the news. You mentioned the single operator model earlier, Caleb's Law, which almost passed it. Well, it was reasonably close to passing in California.
What was it called? What's it called?
It's called Caleb's Law, right? Which is the law basically said that.
Oh yeah, I remember that one.
Yeah, would have outlawed the single operator model, which would have really impacted oral surgeons and the California Society of Anesthesiologists, physician anesthesiologists, kind of led the way on that, and that stopped. That's a big issue. We had an interesting issue here in Arizona, and that even though our issues in Arizona were not related to the single operator model, it was clear that was on the mind of the oral surgeons at the proverbial table. So a lot of things in anesthesia with dentistry, it certainly got a lot of press. There was a huge workup in the major Dallas newspaper. It's unfortunate. There's some improvements that can be made. And CRNAs increasingly, there's more CRNAs nurse anesthesiologists than physician anesthesiologists in this country now, and that is the trend, right? So I think it's important for dentists who are doing these surgeries, who are doing these procedures, and want a more advanced option, right, for someone who's skilled in airway management and ACLS and et cetera, and they do this every day. It's important for them to know about that, and that's why I was happy to connect with you. Part of the reason.
And then I mean, and this isn't a show about bringing up dirt or anything like that. We're trying we're trying to transfer knowledge to our replacements. I mean, that's what it's all about. I had 4 boys.
Trying to increase safety, right? Absolutely.
Yeah,
Decrease the risk.
I had 4 boys, and now they're no longer dependents. Now they're independent, and they each own their own home. And now they got 6 dependents, and I want to make sure the kids at AT still that are going to be treating my granddaughter understands lessons in the past. Another one that was really bad. Now here, we're humans. We make mistakes. I mean, I personally have never made a mistake, but I've read books. I've seen movies. Other people have made mistakes. But the hygienist, the office manager, to get flow going, had the hygienist go in and numb up a kid who was getting 4 quadrants of fillings done.
Right.
And then when the dentist got to the room, he didn't know that happened. He didn't get the Post-it note, so he re-numbed her up. And she OD'd on lidocaine.
Right. Local anesthetic, systemic toxicity. Yep.
And the thing about that is that, so we got a dead baby. That's a nightmare. But you know what his real nightmare was? Is he altered the records. He started erasing and changing the notes. And so now it goes from a civil problem to a criminal problem. And they hung him on the note changes. And I'm telling you, the lie is always worse than the truth. I mean, look at Bill Clinton. When he got caught with Monica, if he just would have held a news press and says, "Hey, do you want to be married to Hillary? You know what it's like being married to Hillary for 30 years? Why don't you mind your own business?" The whole country would have said, "Oh, sorry, dude. I'll change the channel." But he lied. He said, "I did not have sex with that." And the lie kills you every time. And so now we have a dead baby, and the doctor panics and lies and changes the notes. And that's what brought in the whole nother layer of criminal DA.
Right.
And so, Doc, don't lie if you screw up. When you come home and there's a big red lipstick kiss on your deal, don't sit there and say you were at the library,
Right.
Librarians don't wear lipstick. But any thoughts on that? And then the other thing I don't notice is dentists are always mad that they're saying like people, they don't get treated like real doctors. Well, every real doctor I go to always starts with the weight, the height, the blood pressure, and the temperature, and they're giving lidocaine to people. They don't know their weight. They don't know. I mean, when some kid walks in there, does he step on a scale? Do you know what the max is? Does the team say this kid only weighs this much, and this is the most he's going to get? I mean, so it's not taken as serious as your regular family physician.
So there's 2 things there: the malpractice reform thing and the local, I suppose, the difference of the workflow with a general practice versus, or in the operating room even, versus dentistry. Because I picked up on that too. I've even had conversations. They'll say, it frustrates me when we're not getting the same respect or same credibility, et cetera. And my response is, well, there's a whole milieu of reasons for that, right? But I often say, guys, you have it so much better. Right. I have so many friends who are surgeons and physicians and are inherently frustrated. What dentistry did right, as opposed to general medicine, is you guys, by and large, kept the government out of your business. Right. There's the lives I see are so much better than the general physician, the practice physician. Right. And that trickles down to the operating room as well, for sure. And as far as, it's funny, as far as like calculating local doses, surgeons don't. So the typical flow in a general operating room, they'll be like, "Hey, Joe, how much local can I give this patient safely?" They don't worry about that at all. Surgeons don't know that at all, right? They rely on us to do that for them, really, because they're just, they're focused on fixing the bone or whatever else. You mentioned about a very unfortunate case where the kid was double localized, right? The thing this is why I get involved in health policy reform, and I encourage people to get involved, because the malpractice system in our country is so all sorts of screwed up. I have a feeling that dentists went to work that day and didn't say, "Hey, I'm going to have a hugely negative outcome for a child, which is going to result in their death." right? I have a feeling he didn't wake up thinking, I'm going to try to do that, right? He's probably a reasonable guy. He made a mistake, right? And we should be creating systems where when patients have a negative outcome, they have some sort of compensation, some sort of recompense, right? That's part one. And part two is when reasonable people make mistakes, we should be asking, why did the system allow that to happen? What can we improve to make sure that never happens again? And for this individual, we shouldn't be punishing him the rest of his entire life. Now, the lying and the record thing, that's a separate subject, but we should create pathways for individuals when negative outcomes occur that where reasonable standards can come into play. We can get that person into practice as long as it's a reasonable mistake, right? If it's egregious or they're negligent, something like that, that's entirely a different system. But unfortunately, complications occur. And I've even known professionals when a complication occurs, they will tell the patient to sue them so they can get some sort of money to get some sort of functionality back in their life. It's a very unfortunate system, and it's not easy in this country to make policy change, but it's often worth it. And if anybody at the Arizona Dental Association is listening, I can speak. I still am involved in government affairs. We're very happy to work together in that regard.
So you mentioned Caleb's Law. That one. When you go to their website, Caleb's Law says. On July 10, 2017, the California Senate Business Professions and Economic Development Committee made a scary decision to side with the dental industry and not make the changes above that were supported to child advocates, pediatricians, and anesthesiologists alike. We are so disappointed in the state senators who did not stand up for what was right. We will continue this fight. Thank you all who made phone calls into this. Okay, now, in all defense, obviously, I know a lot of these guys. I talk to a lot of these guys.
Sure.
And they're always going to come back with, well, I mean, obviously, if you want more of something, make it cheaper. If you want less of something, regulate it and make it more expensive. And they're always going to go back to access to this care. And they say, Howard, if you get the government involved and you take away, this anesthesiologist right or whatever, then I can already tell you how many of the 10,000 small towns in America you just eliminated access to care or whatever. But but what's your thought? I don't know what you thought of that decision.
Yeah, I in this country, there's so many of us have, I see out in the community there, we have super strong opinions about things. We don't necessarily have all the relevant data, right? So here's the thing. It is not necessarily a good look when every other part of organized of medicine, right? Anytime when there's surgery happening, there is essentially always a separate licensed, fully capable anesthesia provider at the other, whether it's a CRNA anesthesiologist or physician anesthesiologist. That is the standard, hundreds of thousands of cases a year. It's just a hard argument to make for the oral surgeons, right? With that being said, I am not aware of the data. This is not my area of expertise, so I have no strong feelings on the matter personally. Right? I mean, if I had a choice for my kid personally, I'd probably send him to the oral surgeon that we work with because I know the guy who gives the anesthesia there. He's very good. That would just be my preference, right? But I can't make a statement on that specifically. But I do think it's instructive that the American Academy of Pediatric Dentistry, again, who has the time and the resources to come out with a learned statement on this matter, I believe it was 8 years and under, they recommended that a separate anesthesia provider, whether it's an expert that is a CRNA or a physician or a dentist anesthesiologist, whatever type of anesthesiologist out there, be watching the area because, and it makes sense, right? The metabolic needs on those kids are so high, they drop like a rock. I'll never forget my pediatric rotations. I mean, they desaturate so quickly, right? That seems reasonable to me. It is not my issue, so to speak. And I know it is very controversial and, people have very strong opinions. And I'm certainly not trying to criticize the oral surgeons for their practice. And if I was, I would make sure I'd have all my facts straight first before taking a strong opinion on that. And I can't take a strong opinion because, again, I just don't know. That's their thing to work out with their other dental colleagues.
So when I first saw your name, and it said
You said, what a
mRNA.
unique name, Joe Rodriguez. What a unique name. Yep. Go
Well,
ahead.
you know, when I saw that CRNA, I mean, all we're hearing about these vaccines with mRNA, these messenger RNA. So I thought, okay, you're not a messenger RNA vaccine. Are you a carrier RNA vaccine?
Right.
What does the C stand for?
Yeah.
But really, I actually saw that CRNA and I thought, God, that's just like a lot like. So I got to tell you a nurse story. This has nothing to do with anything, but I wanted to bring it to your attention because one of the big threads on Dental Town today, you know, they're always talking about something, is that basically, let me go, the income inequality that women are now 34% of the workforce, and the Marco Jucevic at the ADA, his statistics, he says it's time to talk about the gender gap in dentist earnings ratio, and he's showing that years since graduation that, and, you know, if you graduated in the last 5 to 9 years from dental school and you're a female, you're making 37% less than the males.
Wow.
10 to 19 years, it's down to 20. So the gender gap is twice as big in the last 10 years of graduation than it was 20 years ago. But I got to tell you my story. So my dad is in Parsons, Kansas. I'm getting to a story about how this was an all-male profession, right? So my dad is from Parsons, Kansas, and he has two brothers, Jerry and Mike. And Mike had his eyes on my Aunt Shirley all through high school, and she never gave him the time of day. And when high school was over, he was just devastated that Aunt Shirley was now gone. And he found out she enrolled in nursing school. So he wanted that high school to keep going, drove right down there, and they couldn't believe he was applying to nursing school. And so he was the first man to graduate in Kansas as a nurse, and it was only to get my Aunt Shirley, who's a great catch. And but here's what's worse. When they got out of school, since he was a man, he got offered all the 8 to 5 senior job rates at like 3 times the money of Aunt Shirley.
Oh, wow.
And Aunt Shirley was working third shift, picking up, you know, couldn't even get a full schedule because Aunt Shirley wasn't a boy.
Right.
And then I grew up with 5 sisters. My little brother wasn't born until I was 17. It's called Catholic Vatican Roulette Birth Control. It's another podcast to explain. But my own mom, I mean, I felt like I had the most sex in my own house. Like, we lived next to the Arkansas River. I mean, we lived within a football field of the Arkansas River, and I could swim in it. My sisters had to be 10 feet from the edge. My sisters had to be home when when the street lights came on. If I didn't come home, my mom just would call either one of my friends' parents. Is Howie still over there? Yeah, he's spending the night. You know, so I had this free reign. My mom would give me jeans and iron patches on the knees on the outside, and then put my sisters in dresses. And if they soiled their dress, they were grounded.
Right.
So I mean, from so I wanted to ask you, is the gender gap issue alive in nurse anesthety?
Yeah.
Nurse
anesthesiologist. Yeah. Our nurse anesthesiology. Yeah. So I've looked at the compensation data, and there is a gap. Is it significant? And I'm not a PhD, right? So I don't, like so many people, they pretend to be like data experts on the internet. If you go on Twitter, you'll find someone who's an expert on statistics. I guarantee it. Apparently it's everyone. Is that gender gap significant enough to indicate what you are describing, right? Because what you are describing is, you know, even in that story, and certainly at a broad level, I mean, it's crazy to me to pay people less. I mean, in my world, you're delivering the service. Why wouldn't you? If you're delivering the same service, why wouldn't you be paid the same? You know, all confounding factors being accounted for. But at a broad level, there is a difference between what men and women earn. What is contributing to that? I don't specifically know. I know in our group, there is absolutely it doesn't even enter into our, in our group, some of our highest paid people are females because their work is excellent, right? 2 people, if they're listening, Anne-Marie Dyke and Sharon Gray, they're just excellent anesthesia professionals. They deliver excellent care. So they're paid very well, right? And that's how it should be.
But where I was going with this is not
Sure.
pay. Well, yeah, Uncle Mike. I'm sorry, Uncle Mike and Aunt Shirley, who still live in Nevada, Missouri.
Right.
But you're a male nurse, and
I am.
At 2020, only 12% of the nurses in the United States, according to the Bureau, is male. So what is that like? being a male in
Male
a
member of the nursing
profession.
profession. I know.
Male
It's
member,
funny.
yeah.
Yeah. So in general nursing, right, men are about 12%, but in the CRNA specialty, right, it is approximately 50%, right? So a huge amount of that 12% go into this specialty. It is the highest earning nursing specialty by pretty significant margin. Very different culture, right, than the rest of nursing, et cetera. And I think, for those who do not know, like you said, when people see CRNA and you thought of mRNA, it's very simple. CRNAs have been giving anesthesia since the Civil War, right? Dentists did it first with Wells and Morton, right? Ether Dome, way back. And nurses were the predominant providers of anesthesia really until arguably the 1960s when direct reimbursement came around. This is what I tell folks, look, there's different professions involved in anesthesia. They are all experts, whether it's a CRNA or a dentist or a physician. They get there in different ways. For physicians, the vast majority are board certified. For CRNAs, you cannot practice without board certification. That's the way our profession developed. And I just say, look, there's different ways to become an expert in this field. And there are tens of thousands of CRNAs who practice independently all throughout the country. We have, and your audience, some of them will know about this, but we have this 100-year-long pissing match with the physicians. And that's exactly what it is. I mean, I can bring you historical documents where the exact same arguments are being used. Some of them were sued, like there was a case, Dagmar Nelson, California. They sued her in criminal court for practicing anesthesia. And since that case in California, for about 100 years now, when CRNAs practice, yes, we're professional nurses. That's our professional background, et cetera, et cetera. But our practice is in anesthesia, right? And that's where our focus is. And that's what we do every day. And it's a good gig. But we do have this constant challenge where no one can pronounce our title. So,
but I think that you guys need to hear about what we're saying, thinking about when you're advertising. So I am a DDS, and I did not know what a CRNA was, okay? I get all these direct mail pieces, and it'll be like a finance broker or a wealth management guy, and he's got half the alphabet behind his name. It's just Greek. It's not going to mean anything to me. I mean, it doesn't mean anything. And I'll tell you about the credentials, and I'll tell you, the credentials, and again, I'm not trying to throw people under the trash, but we're just talking about relative issues. You and me are from the hood. There was a dentist out here who's had all the anesthesia credentials, and remember, and it turned out fake. It was all over the news. Valley dentist arrested for false credentials. Pankaj Goyal, Pankaj Goyal, but he had fake credentials.
That's crazy. Yeah.
But these credentials, the point I'm trying to make is you may think you're doing everything right, and you got this dentist, he says, I'm an anesthesiologist. You don't know if it was docs. You don't know if he's board certified. Hell, in Arizona, you don't even know what's fake. This guy had fake credentials. I mean, and then you think that's bad. This is even funnier. I'm from Wichita, Kansas. So this dentist was like 1 year from retiring, and the state board was going from a paper chart system to an electronic digital system, and it just didn't make sense. And this government employee receptionist is looking at, figures out that a dentist in Tennessee died, and he took his name and credentials and all that, moved to Wichita, Kansas, and practiced for 40 years. And they didn't take away his license until he was like 62, and he was ready to retire anyway.
That's incredible. I
mean, so again, so just because you're having an anesthesiologist come in your office, so being in Arizona where this is all of the news fake, so if I was going to have you come in my office, how do I even know that you didn't go to some guy's funeral in Tennessee and just come over to Arizona and say that you're Charlie Smith and practice dentistry 40 years? By the way, with no complaints, no lawsuits, a healthy, thriving business, no training. So how would you even advise that? Because here's my advice, and it's real crystal clear.
Mm-hmm.
You do not stick an IV in anyone. And, remember, the deals about pathology, trees don't get, depressed. Your lawn doesn't get suicidal. So when you look at a sapien, if someone kill someone, that means we're all capable of killing. You've heard this. I've driven in the car with my 82-year-old mother, and she says, "Oh my God, if he changes lanes again, I'd love to shoot the son of a blah blah blah." And it's like,
right.
If someone kills someone, we can all do it. If someone gets depressed, we're all capable of doing it. If someone commits suicide, we're all capable. The pathology defines what we're all capable of. And my gosh, so when you keep saying that this president or this person is a total narcissist, that means Sapien is a narcissist. You know, we're all capable of that. And so I know you're always the smartest kid in the class and you got A's in calculus and physics and all this stuff like that. But dude, you're not an anesthesiologist. And when your root canal goes bad, you don't realize that.
That's crazy.
Okay, we have to retreat it. But when anesthesia goes bad, someone's dead and you're screwed. And of the two, I only have a 2 sample size of a friend that actually killed someone. Wow. And they never smiled again. And they never loved dentistry again. And one of them was, the triangle zone, the Bermuda Triangle Zone, where the veins go back into the brain without the backwash. Just came in. It was a standard toothache. It was a canine. He pulled the canine. No big deal. But he didn't put him on antibiotics. 2 days later, they end up in the hospital, the brain abscess, and then died.
Oh, it's incredible.
And of course, the standard protocol is that if you pull a tooth, canine to canine, in the maxillary, they call that the Bermuda Triangle, you got to cover it with antibiotics. And they went to a full-length trial, and he was the most motivated, happy go-getter. He loved dentistry more than anything. And like 3 years later, he died of cancer. And that whole time period, he didn't even smile. And I think it was all tied together. You know what I mean?
Right.
It just killed him. So, dude, why would you go learn anesthesia when you can page an anesthesiologist at 3 a.m. to deliver a baby? Just don't do it. Just either do it or don't do it, but it's life or death. It's not something taken lightly.
Yeah, absolutely. And it's funny, even when people say, well, I'm going to go learn anesthesia, I'm going to go learn IV sedation. I don't really, again, because I have an economic interest, right? So they're not going to listen to me. But I always think to myself, guys, you're not really learning IV sedation. You're not really learning anesthesia. You may be learning the technical administration and the pharmacology of a few drugs. But anesthesia, perioperative practice, is understanding everything that goes on before, during, and after the surgery, right? As well as the emergencies, right? And again, this is what we said earlier. If you're not getting the volume of cases, if this isn't really your only focus, then you're never going to get that level of experience where you can truly not just, you can do 2 things. You can prevent emergencies from happening that would otherwise occur. That's part 1. And if they do get to the point, right, where all those confounding factors come in and that emergency happens, that's where all the value of that experience and training comes into play, right? You said, for a patient or a dentist, the main question is, show me your national board certification, right? Whether it's the American Board of Anesthesiology or the MD-CRNA or the, I forget the name of the American Board of Dental Anesthesiology. I forget the specific name, right? But those are 3 main groups who have really proven themselves over time, who have extensive training, who have extensive experience, right? I mean,
say the 3 main groups again.
I believe it's the American Board of Dental Anesthesiology, right? The NBCRNA, which is the national board that certifies CRNAs, and the American Board of Anesthesiology, right? And they've gone to some different nomenclature now, physician anesthesiology, but they only certify physicians, right? Those are the 3 main groups. If you have a separate anesthesia provider, again, I'm not commenting on the single operator model, but if you have a separate anesthesia provider, you're a dentist or an oral surgeon or whatever, and you're looking for somebody who's third party, and that's their only focus, show me your national board certification. Show me your experience in this, rather than, like you said, you get, a fake anesthesiologist. That's just crazy, right? And then you can go on the internet and verify these things. Like, you can find my name at the NBCRNA website and how long I've been certified, right? If you want to get real detailed for physicians and CRNAs, you can search something called the National Practitioner Database and look for any potential negative outcomes or lawsuits, right? They get registered in the National Practitioner Database.
I want to ask you a question and pin you down for it.
Go ahead.
So you have to have a nodule removed off your larynx, and it'd just be
Yep.
so convenient to go to your doctor and he does twilight sleep and whatever, and then
Uh-huh.
you wake up Joan Rivers. How do
Hmm.
you and you your 3 posts on Dental Town are about dental surgery centers.
Yep.
You said good afternoon, folks. You talk about that. Tell me what you're thinking about dental surgery centers, and is that Joan Rivers to you? And the other thing that that frustrates me with my 4 boys are perfect. They really are, but their wives are very challenging, and
Okay.
because
Hope they're not listening.
no. What I don't understand is, but it makes me understand consumers, right? Because
Hmm.
my 4 boys grew up with a dentist. They know there's a difference between a dentist and an oral surgeon. By the way, in Ahwatukee, we only have 1 oral surgeon, and Greg Edmonds hired a full-time anesthesiologist 10 years ago. And
Okay.
he said it's not only just safer, but it's business. He goes,
It's more convenient.
yeah,
Yeah.
well, I mean, he just walks in the room and they're all ready to go, and he does his thing, and then he can go
Exactly.
in the next room and do a consult or whatever. He says, I pay him, if I pay him $1, I'm going to make another $1.50 extra than not having
Right.
him. It's a return on investment every single time.
Yep.
He doesn't know why. He can't figure out why anybody doesn't do it. But here's what I don't understand. Like, one of my grandchildren will fall and have a major accident, and they have no idea between the little, they go to the closest convenient little surgical or the closest little
Sure.
emergency deal.
Right.
And you're like, well, and it's like, oh, okay, well, that's like the lowest quality. And I always say so I just get done this. Please don't take my grandchild anywhere unless a helicopter could land on the building.
Right. Right.
So can you talk about the levels of hospital? Because Joan Rivers and having your dentist do an IV.
Absolutely.
And what's the volume of comorbidities? Where would be the best place to have a laryngospasm? Wouldn't it be in a place where helicopters land on top of the building?
Yeah, that's a great. So I have to preface this question by saying my name is Joe Rodriguez. I only represent myself on this phone call, right? Just so, because other organizations, other people may not agree with this next statement. But the truth is, look, we have a saying in this business, you know what you do, right? If all you're doing is giving 2 milligrams of Versed or Valium or something in the long-acting stuff, and that's all you're doing in the 99% of your cases, or you're sedating people for cataracts all day, every day in your whole career, you're not going to be prepared, right, for when that laryngospasm happens. So the best person to have in a laryngospasm or any other type of anesthetic emergency is a person who's most experienced in doing it. Right. And it is common in the community to think, well, I'm going to go to an academic medical center, Thomas Jefferson University. This is where I began to learn this fact. And I'm going to have my shoulder or my back or whatever done by the best surgeon in the country. And I know that because I see him on the billboards. Right. And I got there and I realized, wait a second, that guy's not even in the operating room. Oh, his residents are the ones doing the surgery. Right. And I realized out in private practice with people who are doing it every single day, whether it's dentistry or general surgery, ortho, or anesthesia, those are the people who are extremely good and they have an extremely low complication rate, partially because they're doing so many cases, right? So in your scenario where you're going to a place where you're having a helicopter land on the building, that's the place to go because they're the places which sees the most volume of rare events, right? Big traumas, right? Things that nobody has ever heard of. If you got that type of thing, you need to go to that hospital because they're the ones who are going to have the training to do it and the experience, right? But if you're having your shoulder done, right, or an implant that any periodontist can do, you want to find a private practice guy, and that's what he does all day, every day, and he's accountable to his patients and his community, and he's not hidden in some big bureaucracy of a big academic medical center. That's the Joe Rodriguez answer. People know what they do. Find the most experienced person you can.
That's just when you said shoulder, it hurt because the dentist across the street from me, born in Kansas, went to the same dental school, UMKC, the healthiest guy of all the dentists in there. I mean, he was the healthiest guy, and he went in to have just some little know-nothing. His shoulders kind of bother him, and he went in there to have a shoulder deal, and he died from complications of it.
Jeez.
And it's like, my gosh, I mean, the risk, I mean, this is a very serious deal. You know what I mean?
Oh, yeah. We have a saying, your producer might have to, well, I shouldn't say this. This is a big audience, but anesthesia is easy to do and it's really easy to screw up, right? Or another truism is, it's 90% boredom, 10% sheer terror, because when things go bad, they go bad lightning quick.
Just like a pilot. That's what the pilots say.
And that's the best corollary for a profession.
Yeah.
And you talk about Joan Rivers. I mean, Joe Rivers is probably a good example because my understanding, and again, this is me opining as a third party. My understanding was that it was a physician anesthesiologist, right? They had a third party, but all she did was that, basically lower level of sedation, right? And if you don't diversify your practice as an anesthesia provider, right? Whatever type of anesthesia provider you are, you got to have those skills to pull them out in the moment. Just like we said before, experience, it's often been said, experience is the great equalizer.
Okay, so another thing that these kids are getting misinformation on, or not misinformation, but it's tough.
Yeah.
In dental school, the one thing I learned right out of the gate was in clinic is whoever checked you in to do this procedure, you stay with that one guy the whole way, because you couldn't get two dentists to agree that today is Wednesday. I mean, so at least stay with one coach, you know what I mean? But you have one guy in the dental schools teaching all this medical emergency stuff.
Right.
And then another guy in the same school saying, you know what you do with all that? You load up the syringe, and then you always have an orange there, and you stab the syringe. Just call 911, shut the hell up, maintain airway, don't do any of those drugs. And I felt like, well, I can't weigh in on this because I've been lucky. I mean, I'm at 48th and Elliott in Ahwatukee. Have you ever even heard of Ahwatukee?
Oh, yeah. I got a friend
lot of
down there. We cover at Banner Casa, yeah. So yep.
Yeah, a lot of people in Arizona never heard of it. But anyway, I'm 1 mile from the fire station, and probably 3 times I've called 911. Two were fainting, and when one fainted, when her head hit the ground, it sounded like a bowling ball. And then the other one was for my office manager, who I thought was fainting or losing it or whatever. But anyway, I called them, and in like 1 minute, 5 firemen walk in. It's like, I'm not going to be loading a medical emergency kit and loading syringes. And so our medical emergency training is, if in doubt, call 911, and don't do it as a secret. Go to the phone and say, I'm calling 911 for just get 911 on the phone. Is that bad advice? Should I really be taking my medical emergency kit and seeing the expiration dates and, renewing all the little carpels and stuff? I mean, I don't know how I could compete with 5 firemen.
No, you couldn't. I think it's not bad advice in terms of, hey, if there's an issue, get help, right? If the standards are to have those certain basic medications on hand, and certainly, I was sedating a patient at Perio's office, and I put an IV in, which again, a lot of dentists do, and she Brady down to like the high 20s. Right. And I ran over, I got the atropine, I gave it to her, and the problem was fixed then. But the periodontist didn't even know. He was, he knew, I told him, but he was like, oh, okay, looks like everything's great now. Right. So it's certainly, and those things can be life-saving, right? If somebody got exposed to an allergen, you give them epinephrine, right? Or they become very bradycardic, and you see it, and you look and you give the 0.4 milligrams of atropine, even if there's an underlying issue, like if they have, sick sinus syndrome, or they're having a coronary event, that intervention can give them mileage before they get to the main, whether it's the cath lab or the emergency room or whatever else. So certainly it's good advice to be up on those basics, right? But it is very good advice to call help early and often, right? We have a saying in this business, there are some airways that can only be fixed with a knife, right? That refers to a surgical or a crike or a surgical airway, right? Something that paramedics are trained in. And that the only way to have a good outcome in that scenario is to call for help early, right? And to your other point, it's funny, you're talking about the oral surgeon down in Ahwatukee. I know the name, by the way, but another guy we work with, he actually said to me one day, he was like, you know what, Joe, you and Allie, you guys are the drug for me, because you make, and again, this is just his experience I'm commenting on. I don't mean to sound, like we're elevating our services, but I think there's an argument to be made to say when you have a third party involved whose only focus is that, whose education spans the entire perioperative period, who does this all day, every day, it adds a level of efficiency and comfort for that person doing the procedure or during the surgery to just make their life easier, right? So they're not managing it themselves. And again, I'm not here to criticize the practice of others. It's not my style. But I am saying I think there's a legitimate argument to be made along the lines of what you've been making.
And you guys, I just get, if you go to the anesthesiology section on Dentaltown. I mean, it's just case after case. And these are not rare cases. Like I'm reading this one to you right now. 7-year-old. This is what is the date on here? This was just January 19th, 2021. I mean, that's, 2 months ago. A 7-year-old Jackson girl died after her
I
heart
saw that one.
stopped during a tooth removal. Here's how to handle, and they got a GoFundMe page going, and help Ashley and Luke, and my God, 524 people. But I mean, so I mean, did you read that one or?
I was familiar with it. I think the patient was sedated. I think there was only. I'm not sure the facts of the case, so I don't want to say. But I mean, case in point, like I do straightforward pediatrics as a part of my practice, right? So and again, it's a volume game. You get exposed to those problems, the clinical challenges, and if you get a kid like that, those kids they desaturate so quickly. That is not the time to be thinking back, right? Especially with kids because it's so fast. It behooves. I think it's reasonable to say, for kids and other situations that are like that, it's great to have a second set of hands. And again, as you can tell, Howard, I'm trying not to sound self-serving here. I'm trying to.
No, I don't care. I mean, it's the same thing with profanity and people that are perceived that they said something, anti this group or that.
Anti something.
It comes from the heart. Was this person making a joke, or is he truly a racist, sexist asshole? And but anyway, this Jocelyn had a rare developmental disorder, Cohen syndrome, and we had another case like that in Tempe where somebody did IV sedation, and it was on someone who had trisomy 23, and I guess their heart is very different than a normal person, non-trisomy. And so again, and this is something that where I'm from in Kansas, they realize this. You realize that all these states kind of divided up economics. That's how democracy works. So I said, okay, you're the capital, and now we're going to build a big university. Why don't you put that in my little town that doesn't have any money? And then these little universities got really, really big and had med schools in all of them, but they're in towns of like 30, 40, 50,000 people. And they realized, well, you're not going to have that rare Cohen syndrome in a town of 50,000. And so we're primates, and our two closest cousins are chimps and bonobos. We got a distant cousin named an orangutan, and your long-distance cousin, Crazy Eddie, is a gorilla. That's the farthest one. But when you do a residency, don't look at U.S. national news. And I want to know the population. If you go to L.A. or New Orleans or Manhattan, you're going to see everything. But if you go do your residency in Lawrence, Kansas, I mean, you might not see a pulpotomy. I mean, you just and a lot of these diseases are 1 in a million diseases.
Right.
So Phoenix has a metro of 3.8. So if it's a 1 in a million disease, there might only be 4 cases in the whole city. So why are you doing a residency in some town of 12 people? So remember, the number of primates matters. That is the big deal.
That's a great point. I totally agree. It's funny, dentistry and medicine, the CRNA worlds, they overlap to a degree, but they don't often interact, and we use different words for things, et cetera, et cetera. But you know what? The underlying principles are the same, and is exactly what you're saying. You need to get volume of experience. Very early in my practice, even at my training, I went to the toughest hospital I could find that was available through my program. It was Albert Einstein Hospital in Philadelphia, right? It was a very tough place. I came out here, went to the West Valley over at Boswell and Del Webb up in Sun City, right? And arguably the sickest patients in the state because of those patients. I mean, if we saw an ejection fraction over 20%, we were like really happy, right? Normal is like 60, right? And that again is something that we've been able to bring into these offices because we have an older population here in Arizona, and we're able to screen some of these things out. We've even caught things where patients will be all signed up for sedation and their implants, and we'll say, look at the history of this patient. They've got cardiomyopathy, et cetera, et cetera. We need to get a workup, and we've had cases where they have significant coronary intervention before having a dental procedure, even. So it's nice again to have that second set of eyes that's looking.
Yeah. So now I feel bad because we went over our hour, and I still have some questions left. Can you? You got
Yeah.
to go, or can
No,
you
no,
stay
no. I
for
don't have
some
anything to
overtime?
follow. Yeah.
Okay, so now I'm going to open up a whole nother can of worms. You're going to wish you never even knew my name. Now let's step down from what you're doing and let's go to oral sedation.
Okay.
Oral sedation. A lot of dentists, and they're my drinking buddies. I mean, these are good guys, but they just get
Sure.
like a little bottle of, and they might be Valium, or it might be
Sure. Some
what's
sort
the
of
fast acting?
benzodiazepine,
What's the fast acting valve?
triazolam, I
Yeah,
think is
yeah,
one. Yep.
yeah. And you know what? And there are 30 years. If someone's not quite right, they go, hey, assistant, go get that bottle in my room and go get two and come do that. And oral sedation. What do you think about that?
Yeah, I think for the vast majority of the population, again, this is just my anecdotal experience given out. For the vast majority of the population, I think that works well. I believe in Arizona, every dentist can give a single dose of a benzodiazepine. I think it's triazolam without any, it's not, obviously it's not very titratable, right? You can't really change it. It's a single dose. Any dentist can do it. And I think that speaks to the disadvantage of oral sedation. There's advantages and disadvantages, right? The disadvantages, you just can't give more. It takes a long time to kick in. And if you do reverse it, right, you're going to, let's say you give somebody a bunch of benzo, right, and they're getting, way over sedated, and you have to give the reversal or Mazicon. Those are drugs you're unfamiliar. It can get messy, right? The vast majority of people, it's fine, right? But in those scenarios, for people who need more, again, that's where it's advantageous to bring in an expert like you and I have both been saying now. I think certainly wouldn't want to interfere with that, because that can help a lot of people. And I think dentists get I think unfairly picked on for dental anxiety, right? But I see patients in the operating room every single day, right? And they're super nervous in the general operating room too. So I think it's a good thing for the community. No safety issues have been raised about it, so I think it's great for people to have that level of flexibility, right? As long as we're not overdoing it.
And then I can't let you go without asking
Sure.
nitrous oxide.
Yeah.
What do you think about nitrous oxide?
It has its place, right? It's not ideal in some scenarios, especially if you're doing it all day, every day, right? There's some negative environmental impact, and there's arguably better ways to take care of some of those patients, but it does have a limited place, I think. Certainly wouldn't want to take an option off the table then that's effective for folks. And certainly the environmental impact is larger as well. I have all but eliminated it from my practice, partially because, again, there's other ways to do it, and it's a negative environment. I think it's important. I like clean air, clean water. So I've eliminated it from my practice, but it does have a place in limited applications.
And tell the old kids, and I want you to opine on this, because in the old days, and this is clear back in the 80s,
Sure.
there was, I know of a couple of nitrous oxide accidents, but the machinery, you could turn it up to 100% and the oxygen down to 0.
Right.
And so I know at least half of my friends hate everything about the government, including myself. I mean, it's like,
Sure.
I'm not a big government fan, but it's
Sure,
like but it's checks and balances. Absolute power is absolute corruption, and you
That's
need
right.
checks and balances. When I grew up, you walk down the street, every third garage was some man, his son, and his uncle trying to get his shitty Chevy to run, and it wasn't until imports coming in from Japan, and those little Volkswagens, and everybody was laughing at them. And GM sold half the cars in America, and today they only sell 30% of the cars, because it didn't take Americans long to figure out that damn Volkswagen didn't break down for 200,000 miles, and you couldn't keep a Chevy running. So competition is always good, and I'm all for competition. But that regulation, it stopped. I mean, I have not heard of a nitrous death since that nitrous machine will only go down to 70%. And the same thing with our, it seems like when I was little, they would always sedate you with a narcotic. And the only thing that would happen after that, you needed a tincture of time for it to wear away. And then they went into reversibles, like Versed will put you down, Reverse will take you out. Would you say that nitrous and sedation is a lot safer today than 1980?
Yes, I would. Undoubtedly so. And primarily, not just the types of drugs that we're using, right? The training is better, but also monitoring is better, right? We spoke about that tragic death earlier in Yuma, Arizona, and it was because of two things, right? Primarily, maybe three. Education played a part, but primarily it was number one, human communication, right? And the monitoring, like that, it was not communicated to the person watching that monitor. Hey, you can't silence the monitor. That's anathema, right? So the monitoring is there, and that's improved safely greatly. And like we said earlier, by and large, there's a flip coin, right? Anesthesia is sedation. It's super safe. It's also super dangerous. It's really easy to get dangerous very quickly. I could tell you stories that I was dealing with today. So the answer to your question is yes. But that doesn't mean we get more lax on things necessarily, lax in our vigilance. That just means we approach things differently.
Okay, final question, because I know you're probably wondering when I'm ever going to shut the hell up.
Oh, no, it's all good. This has been fun.
I want to bring the historical perspective to the kids. That's what I think old senile dementia people like me can do. So when I was little and I got out of school in 87, the doctors were the bad guys because old grandma has cancer and you won't give her something strong and you're saying she's going to get addicted and God, she's 80 years old. She's dying of cancer and we wouldn't give anybody anything strong. So the whole push was, come on, dude, give him some Vicodin, give him some Percodan, give him some this. And when I got out of school, people don't realize this, that every month the rep would come by and give me a free box of samples of different Vicodins and all. Everybody, if I went to any of my friends' offices to go to lunch or whatever in their office, they might have 5 or 6 boxes. I think at one time I had like 10 boxes stacked up. They gave them to everyone, and the message was, why do they have to be in pain after a dental procedure? Just man up and give them something strong. They're not going to become addicted. Oh, my God, did that swing clear to the other side?
Oh, man. It sure
did. My God, you evil bastard. You gave my daughter Vicodin, and now she's working a stripper pole in Apache Junction. And my gosh, so a lot of these young kids are like, they're like afraid to ask their endodontists, like, do you ever give them Vicodin because they're afraid they're going to be labeled like a whore, an adulteress, or
I know.
So
you're making the opioid crises worse. Yeah, I've heard
so how do you balance? I've lived through 2 extremes. You bad boy won't give it, and now you're a bad guy because you gave it. Which one is right?
Yeah, I think that the key word for folks, whether you're controlling pain after surgery with oral medications prescribed at home, et cetera, or you're in the main OR, et cetera, the key word is multimodal. Right?
Multimodal?
Multimodal, right? You have to hit different receptors for pain control. It is not right. So, give you an example. When I got out of my program, we were giving loading people up with narcotics and IV narcotics, and they would be, their end-tidal CO2 was off the charts because they're barely breathing. But now we use gabapentinoids. We use acetaminophen, which is a widely available and super cheap drug. We use an NSAID, right? And those when you're hitting those other receptors, you are decreasing the patient's perception of pain. And you're also making, when you do have to give an opioid, you're making it more efficacious, right? You're making it more effective, right? So the opioids have a place. And again, I am a what works, what solves the problem. Let's do that, right? Let's work backwards from the solution. And the solution is patients get their pain controlled, right? But we don't experience those other problems. Narcotics have a place. Opioids have a place. I have not given them up out of my practice. I'm not religious about it like some folks are. But if there's ways to decrease that and minimize the side effect profile of those opioids, even better, right? And I think that's the good thing that has come out of at least as far as a clinician, that's the good thing that has come out of the opioid crisis is we're thinking more about multimodal analgesia. What are the other medicines we can give? When I sedate for dental cases, I don't give any. I actually don't give any narcotic at all. There's no need, right? I can do it with other drugs, whether it's alpha-2 agonists or ketamine or propofol or whatever else. So it's good to cut down, but it still has a place.
Okay, and I wish this one's so long. I almost wish you'd log on to answer it, but it says the name of the thread is and this is right up there today. This CRNA, a threat to DA and OMFS.
Oh,
and it
says, I'm gonna have to log on. Yeah.
It says basically
Oh, we
It's
could have
a
talked about this one the whole time. Oh, man.
Yeah, it says American Association of Nurse Anesthetists, and anyway, it talks about the whole deal, and then the
Right.
dentists go on to say that that this is a threat to our sovereign profession, and it's guys like Joseph. It's guys like
Yes.
Joseph. You're ruining everything, Joseph. Did you not know that?
Yeah.
But
Now I know.
I'll send you that thread, but I wish you would weigh in on that one and
Yeah,
tell me.
I'm very, very, that's, as far as my professional activity, spent a lot of time on scope of practice reform. So I've heard literally everything under the sun, CRNAs and vice versa, right? I've heard CRNAs opine in the same way. And I got to tell you, Howard, I mean, it's all crazy. It's all crazy. This whole thing that any profession is going to end any other profession, right? You got done saying earlier, like, competition is good. And you know what? This is the main takeaway. Professions overlap, right? Even within dental specialties, guys overlap, and they don't like that either, right? But the fact is, CRNAs, DAs, MDAs, or PAs, whatever they're called now, physician anesthesiologists, they all overlap in the world of anesthesia. That is unique, right? Another good example is orthopods and DPMs. They overlap, they compete. Another example, back when you were coming out of school.
Wait, I didn't know what that
was.
Orthopods and DPMs.
Oh, podiatrists, right?
Okay, podiatrists and what?
Podiatrists and orthopods overlap because there are MDs who do foot and ankle surgery. This is a great topic. MDs who do foot and ankle surgery, and there's DPMs, and they only do foot and ankle surgery, right? There's optometrists and ophthalmologists, right? They overlap because optometrists essentially do primary care and a number of other things, right? And then ophthalmologists are legally authorized to do it all. And that has to do with not just their training. There are differences in training, right? But there's not necessarily differences in outcomes in specific areas. That's a take home. There's just professional overlap. Look, there is so much work out there, right? We are seeing COVID exacerbated it, but we are in the beginning of a silver tsunami, right? There's a ton of work to be done out there. People need these services. And to say, look, there's 50,000 CRNAs in this country, right? And I think there's, I don't know, how many dentists are there in the country? There's, I'm guessing
211,000.
How many?
There's 211,000 living Americans with an active license from the state board.
Okay.
There's 150,000 general dentists working 32 hours a week or more, and 30,000 specialists working 32 hours a week. So there's about 180,000.
Right.
But a lot of people, if you go to these meetings, there's a lot of old timers that come in here, and
Sure.
But anyway, that's the deal.
Yeah. I think CRNAs are a relatively small group, right? So, this whole, the sky is ending. We talked about historical references earlier. The truth is, that statement has been flying around forever. And you know what? The world isn't ending, right? There's plenty of work out there for everybody. What society needs to do, we need to make sure everybody can do everything they can to benefit patients. That's what patients need. That's what drives up access. That's what decreases costs. It's a very simple equation, right? If you have the relevant skill and training, you should be able to offer that service to society. Now, and then you have various safety boards. You have your government regulatory boards. You have your accreditation organizations. You have local quality committees, of which I am part, right? Who looks at individual practitioners and say, you may have a DDS or an MD or a CRNA, but you know what? You're not meeting standards. You're going to have to do something else, right? All these safety precautions are in place. And then once everyone is doing everything they can to benefit society, there's going to be competition that exists, not just within professions, right? But between professions, but within professions. There's a lot of CRNAs who compete with us directly, right? And we may not even like them. I'm not personal friends with all CRNAs, right? Some are I just don't like them. They're just not good people. And that's just the nature of people, right? So that's the point. I think those threads are all hyperbole, and it is what it is. I mean, people just need to be.
So last but not least, I just emailed you the link to that thread so you can tell
Thank
us.
You.
I think you should show your face. I mean, if you're going to ruin all of dentistry, you should at least. I mean, you should. Yeah, I'm the guy. I'm gonna.
Yeah.
I'm taking down dentistry, dude. But hey, if someone's listening to you, I mean, obviously you don't do this in Canada or Quebec, and I doubt Pennsylvania. What is your territory that you will go into? Is it just all Arizona? Is it Southern Arizona?
Sure.
What
so our group has, you mean our group? The one that I'm part of? We have a small presence, so we're kind of on the business evolution cycle, right? We started 5 years ago. We actually, the first patient I ever had, the first case we ever did was with a periodontist. That's probably why we have that's why we have a special connection to the dental community, especially Allie and I. We do a lot of others, Kirk and Jazz, but we've been doing this for 6 years now, right? And last year we had 100 active clinicians, 100 CRNAs and MDs across the state.
Wow, that's
Yeah.
huge.
It's not a small, and we've tried to run things right. You try to commit to sound management principles, right? To do things differently than other professional service firms. And so we've been able to have some success in that area. But yeah, we cover every major market and most of the minor markets in Arizona. We do have a small presence out of state as well. And, if we continue to do that, that remains to be seen. If we can do it well and maintain quality, maintain standards. And the bottom line is we're a referral service, right? So if we don't get a referral from a surgeon or dentist, I often call dentists surgeons just because it's, I generally only work with surgeons. If we're not getting that referral, then, we don't have work. So we got to keep up the quality. As long as we can do that effectively and deliver on our mission to create value for the broader community, as well as run a healthy business, right? Because nobody in our group looks for free. If we can do those two things, we'll continue to do it.
And you are on Twitter at JRodCRNA, but on your LinkedIn profile, you say
I gotta update my LinkedIn profile.
And on your
JRodCRNA, yeah.
Yeah, and on your LinkedIn profile, your link to your website doesn't work. You put in azas.co.
Oh, see, I'm not on LinkedIn as much. I gotta get on there. I gotta update things.
All right. Well, hey, can I call you Joe Rod?
Yeah,
absolutely. What's the 51?
51 was the year my father was born, actually. So I like that number. That was my number when I played high school football, actually. So it's just
that's romantic.
Wow.
Yeah. My dad was born in 38, and I'll never forget it. I mean, it is a special year.
It just sticks in there. Yeah.
Yeah. Well, hey, man, you're a class act. You're a brainiac.
Oh, thank you, sir.
It was an honor to have you on the program, and thanks for coming on Dentistry Uncensored and talking about all things politically incorrect. I hope I didn't make you too many enemies.
Oh, not at all. It's all good. It's all good.
If anything ever comes up,
I'm okay with it.
All right, buddy. It was an honor to podcast you.
Thank you, my friend. Have a great day.
All right, you too.